First of all, let's see about vocal cord. So vocal cord is a peculiar structure in the aerodigestional tract. All other aerodigestional tract structures are bound by columnar epithelium, but this vocal cord is bound by squamous epithelium. So it has squamous epithelium, it has lamina propria. So lamina propria is of 3 layers. Okay, superficial, middle and deep. Superficial layer is called Reinke space. The middle and deep layer form together form vocalis ligament. Lower to or below all these structures lies the vocalis muscle. So that's all you need to understand about the histology of the vocal cord. The length of the vocal cord and its measurements are very important. Usually the length of the vocal cord is 14 mm maximum in pediatric age group, 18 mm in females, 24 mm in males. So apart from that, another measurement you should be very clear is the distance between vocal cords. So the vocal cord, this is midline, in midline position. If the vocal cord is in paramedian position, the distance between two vocal cord is 3 mm. The distance between the vocal cord we can call it as glottic chink. Okay. Then cadaveric position means the distance between two vocal cord is 7 mm. So gentle abduction means 14 mm. Full abduction means 19 mm. Okay. So you have at least some basic understanding about the histology and measurements of the vocal cord. Now we can enter into the vocal cord palsy. So relax. Before knowing about the vocal cord palsy, I'll tell you a small story. Surgeries are being done over the last 3 centuries only, but anatomies have been evolved 5 centuries, 6 centuries back itself. They are constantly working on the cadavers to found a better anatomy and better understanding of the human body. So previously anatomists found out that all the abductors and adductors of the vocal cord are supplied by recurrent laryngeal nerve. Okay, so then they found a surprising thing in the bilateral abductor palsy of a patient. So while doing cadaver dissection, they found the vocal cord in paramedian position. So it was very surprising for them. If both the abduction and adduction are supplied by recurrent laryngeal nerve, then the vocal cord should be in recumbent position. So here, what is the recumbent position? It is none other than cadaveric position. Cadaveric means the cadaver is without any life. No. Similarly, if vocal cord is without any life means it will be in cadaveric position. So 7 mm. The distance between two vocal cords is 7 mm. This is the recumbent position of the vocal cord. So if both abduction and adduction are not working, this is the position of the vocal cord. But to their surprise, it was in paramedian position. That is, if recurrent laryngeal nerve is palsied, but still the vocal cord is in paramedian position. What it implies? So abductors are not working. Only adductors are working. So they call bilateral abductor palsy alone. So they were quite puzzled by this. So Simon came out with the law, Simon's law. He told that phylogenetically we have respiration as the priority. The speech evolved later only. So the muscles needed for respiration is abductors. The muscles needed for speech is adductors. So the phylogenetically newer muscles will be the later muscles to undergo palsy. So that's why if recurrent laryngeal nerve is palsy, the older group of muscles, which abductors alone palsy, but adductors are not palsy. That's why the adductors are in the adductors making the vocal cord to be in paramedian position. So this is not widely accepted. Okay. Then came Wagner and Grossman hypothesis. What they told now, they found out that, or they gave hypothesis that cricothyroid muscle, which is actually the tensor of the vocal cord, the cricothyroid muscle will also have some adductor function. So though the prime adductors have lost their function, this cricothyroid muscle is giving up some adductor function. That's why the vocal cord are found to be in paramedian position. This Wagner-Grossman hypothesis is widely accepted one. So we are clear with the two laws, right? we enter into the how the presentation of the vocal cord palsies are being given. First, the function of the superior laryngeal nerve is sensory supply of the vocal cord till the vocal cord. Below that, sensory supply is by recurrent laryngeal nerve. Fine. Secondly, it will supply the cricothyroid muscle. Cricothyroid muscle actual function is tensor of the vocal cord. Lengthening of the vocal cord is being done by cricothyroid muscle. Other than that, all the muscles supplied by recurrent laryngeal nerve. Okay. First, we will say about the unilateral SLN, bilateral SLN. Then we will say about unilateral RLN, bilateral RLN. Then we will say about both nerve palsy. First, what I told the function of the SLN? It has sensory function. So if the sensation of the vocal cord is not perceived, means it will not perceive the saliva. If saliva is dripped over the vocal cord or larynx, means it will not be sensed. So it may lead to aspiration. Then the pitch of the vocal cord is affected. So cricothyroid muscle helps in lengthening of the vocal cord. It helps in raising the pitch of the voice. That's why if unilateral SLN means there will be huskiness of voice, mild aspiration. Then bilateral SLN palsy, there will be huskiness of voice, there will be aspiration. So aspiration will be more severe. So unilateral SLN palsy, no treatment is needed. It can be managed conservatively. Bilateral SLN palsy, the saliva found over the larynx is not sensed by our SLN, superior laryngeal nerve. So that's why to avoid aspiration, we can close the larynx. How? Epiglottopexy. We can close the larynx by doing epiglottopexy. It has very much poor lifestyle only, but still that is the only option. Or we can do a tracheostomy and cuff the trachea. That can avoid aspiration or dribbling of saliva into the vocal cord. Then going into the RLN palsy, unilateral RLN palsy, as I already said, one vocal cord will be normal, other vocal cord will be in paramedian position. Okay, so unilateral RLN palsy, one vocal cord will be in paramedian position, other vocal cord will be normal. So this causes hoarseness of voice. Okay, unilateral RLN palsy, no treatment is needed, can be managed conservatively because other cord will compensate for the lost function of the paramedian position. So it will cross the midline and it will touch the paramedian position, palsy vocal cord. So it will compensate the voice function, but still there will be some hoarseness of voice alone. Then we enter into the bilateral RLN palsy. Both vocal cords will be in paramedian position, so it will not meet each other. Also, it will meet each other because there will be some adductor function supported by the cricothyroid muscle because SLN is intact, but there will be no abduction. So if there is no abduction, means what the patient will be having? The patient will have difficulty in breathing. The patient will come in stridor. So bilateral recurrent laryngeal palsy, the patient complains of stridor. We should do tracheostomy. Then we should plan the surgery of the patient. If both nerve is in paramedian position, means we can do type 2 thyroplasty, that is lateralization procedure of the vocal cord, or we can do cordectomy. We can remove the posterior aspect of the vocal cord, any one of the vocal cord. We can allocate space for respiration. So respiration will be normal when the patient is at rest, but it is not entirely normal because we are creating a small space for respiration. That procedure is Dennis-Keshima procedure. So entering into the both cord palsy, if there is unilateral both cord palsy, means as I already said, there is no abduction, no adduction. One vocal cord will be in cadaveric position. This is also a serious condition. So the gap will allow aspiration. There will be speech difficulty also. The patient will be having difficulty in speech, difficulty in breathing. Again, the treatment is medialization of the cord, which is type 1 thyroplasty. For bilateral both cord palsy, again it is a serious condition. Both cords will be in cadaveric position. There will be no speech at all, and there will be more of aspiration. Respiration will be normal in both cord palsy, but there will be aspiration problem as well as speech problem. What we can do for those patients, we can do medialization of both cords, that is type 1 thyroplasty, so that the patient can survive a bigger scar.